Thank you for joining us, and thank you for hitting the recording button. We want to make sure folks who couldn't join us can also listen in. Thank you for joining us in our coalition conversation spotlighting one of the 9 action plans we launched in late July, just 2 weeks ago. In today's webinar, we'll be hearing from the individuals who wrote and worked closely with the action plan designing a targeted nursing home recertification survey. For folks who haven't had the chance to yet, we would encourage you to introduce yourself in the chat. I was mentioning that one of the coalition's strengths is that we really have brought a diverse group of voices together, and we'd love to see who is joining on our call today. Welcome, Sue. Welcome, Jane. And before we get into it, I want to first thank the John A. Hartford Foundation for generously funding the Moving Forward Coalition. This work would not happen, it could not happen without them. And I see some of our colleagues at the John A. Hartford Foundation also joined. So hello, and thank you for your continuous support. In terms of our time together, I'll be sharing a little bit more about the coalition, the Moving Forward Coalition, and what an action plan is. And then I'll pass it off to Heidi Steinecker and April Diaz to share about their action plan designing a targeted nursing home recertification survey. And then we'll have some time for Q&A. So do hold on to those questions and chat them in when you can. We'll be keeping track of that as we go. And finally, I'll be wrapping up with ways you can stay connected to the coalition and engage with the action plan. So who is the Moving Forward Coalition? I know many of you on this call today are in the coalition. We are a diverse group of voices, individuals, organizations who have come together, committed to drive specific, actionable improvement in nursing home quality of care and quality of life. And I think there are about 1,000, plus individuals, including advocates, CNAs, nursing home residents, providers, direct care staff, from across the country who are in this coalition, making this a sustainable network to continue this vital work. Our purpose is to develop, test, and promote action plans to improve nursing home resident quality of life. And we just hit the end of year 1 and are going into year 2, which will mostly focus on the testing of the action plans. We started this coalition without a vision or mission, and we developed it with many of you on this call and our partners. And our vision is that every nursing home will be a community in which lives are nurtured, residents are empowered, and where people want to work. Our mission is that we will make vital changes in policy and practice through the power of bringing diverse voices together now. And this is truly the foundation and our core tenets of this coalition. So many of you may already know what an action plan is. For those who may not know, we started this coalition by looking at the recommendations in the NASEM report that was published in April of 2022. And this report emphasized the importance of a holistic approach to nursing home quality improvement. And we took this really long report and identified which of the specific recommendations we could prioritize as items that could be acted on and implemented now. So we had this structured process, and ultimately the priorities that were identified had aspects of all 4 of these boxes on the left: equity, sustainability, feasibility, and collaboration. And these are some screenshots from our many calls developing the action plans this past year, where we looked at emerging research, new partnerships, so that the right people were at the table, committee collaboration, and ultimately considering what matters to residents to build the 9 action plans we published 2 weeks ago on our website, all focusing on a specific element of improving nursing home quality. We'll chat in the link so that you can take a look at all the 9 action plans, but in today's call, we'll be learning more about one of these, which is designing a targeted nursing home recertification survey. And with that, I'm going to pass it off to April Diaz to share a little bit more about that action plan. April?
Yeah, thank you very much. We're very excited. We spent a good portion of this last year developing the action plan, which was posted, and hopefully all of you had a chance to review. But really looking at, and I know that there's been a lot of question about this action plan, is what is our intent and goal? You know, really truly looking at it, is the goal within the Moving Forward Coalition that we were given was to provide efficient and use of resources to improve quality assurance in nursing home oversight. We also know that to do that, we would need to look at our resources that we have, which are very limited. As many of you have seen, there's been a published report from the Senate of Aging and Hearing report that details some of the struggles that state agencies have regarding ability to maintain oversight of nursing homes under the current process. It requires now for us to be creative and to look at ways of innovation. And so out of that came our proposal for the targeted survey recertification survey. Our focus will be that's going to be data driven. Our goal, as we've outlined, is a 2-day recertification within certain criteria. This is not going to be applied across the board. But with that is we really need to look at how in our purpose, in the resources that we have for state survey agencies, that we can be better and effective in oversight and timely complaint investigations and in maintaining timely recertification surveys that are supposed to be within a 9 to 15 month range. With the ability and to do that is to understand that we have a compliance regulatory framework in which we need to make sure that we have quality assurance. We have traditional and complaint surveys. We need to do this a little better. We need to be consistent, and rarely the current survey process has been able to do that. This was pre-pandemic, and it continued and amplified post-pandemic, the struggles in which we have within our process. We look at, in this targeted resurvey certification process, the ability that will allow state agencies to get in timely for those complaints, as we mentioned, and do recertification process. We are going to be working very collaboratively with identified state agencies, as there's been some question of what specifically will be in the recertification. That is part of phase 2. We will be working with state agencies in developing what this targeted recertification survey will look at. We do know in our goal is that this will allow our oversight and data driven process. We hope that this will also, we're going to test and validate in phase 2. We heard very clearly from our resident groups that in the current survey certification process, their voice is rarely heard or contributed. So as we work through this, we'll be bringing through the advocacy groups and focus groups and resident survey to get that resident voice to be key in the first part 1 of the day. We will be looking at criteria with the state agency in which facilities meet criteria for a targeted resurvey and which facilities will continue with the current recertification survey process. Every facility will still have a recertification survey. Those that are criteria that we're looking at is those individuals who meet, for example, compliance history. That's already a factor that CMS uses to rate in their last 3 years of compliance survey. Has there been a change in ownership? If so, then they will have the traditional recertification survey. We will be working with the state agencies in this second phase in defining those high-risk quality measures that would determine somebody that would qualify for a recertification survey that's targeted versus the traditional in high-risk areas, such as what is their staffing measures? Is that one that we will use? That has to be answered as part of year 2. Which high-risk quality measures will be used to determine that someone qualifies for this targeted recertification survey. So we do have a lot of work ahead of us, and we have a lot of people that's interested in working with us in this process. The main thing we want to make sure is that we need to be smarter and more innovative in how we do our complaint surveys, how those annual recertification surveys are done so that we can get those things more timely, get the enforcement, get the oversight that's required, make sure those facilities that are struggling with compliance history has those state agency oversight more effective than they do currently, and be a little smarter and more applicable in how we use those resources. So that's kind of a general overview of what it is. As I said, the action plan does walk through the steps pretty clearly. And phase 2 is a lot of the work of what does this look like? What is included, what is not included, and we have to test it. So some of those questions will be answered as we go forward, and we're going to need all of our partners involved in that process to make sure. And Heidi, you might be able to add some more in this and how we handle equity and how we're getting our stakeholders involved, and from your lens and your history as well. And I think you're muted. I'm sorry.
Yes. No, thank you, April. And thank you everyone for joining today. I'm Heidi Steinecker, and I'm happy to join this effort and be part of the team that's working on this, as we do need reform. I think we've known that for decades, but I think obviously when you see the data percentages of how many people perished during the pandemic unneedlessly, right, with excess death, it really has an inflection point right now where we have an opportunity to take that movement forward to be able to make some concerted changes that need to happen. So currently, I do work for Ernst & Young as a public health consultant, working with global governments across the world who are looking at this same issue, as we are looking at more and more of our global population aging and entering different types of long-term care health facilities. And I've seen that various different types of systems. And formerly, I was the state survey director of the state of California, where we have 1,200 nursing homes. And to answer some of these questions, as we're kind of looking at the why here, is for many years, we've had the state operation manual from CMS that is a one-size-fits-all approach. So it doesn't matter if you are a wonderfully working nursing home or you are a nursing home that is struggling. It was always a one-size-fits-all approach. That does not work when we have severely limited staffing resources in state surveys. We also saw that a lot of our state surveyors retired during the pandemic. And so we have a huge workforce loss of institutional knowledge. And we'll say that there is some bright hope there around the corner, is that I also saw when I was in that position about halfway through the pandemic, that we also had several people who were unfortunately burnt out from direct patient care from the pandemic. And you started to see more applications come in to become a surveyor. But I do need to stress, and I love Senator Moore's comments about, what about states, about having a certain amount of ratio of how many surveyors per facility. That would be lovely. But I noticed, and I've worked with many states across the US, that they have these postings up there for months and months. It is very difficult to recruit and retain these very difficult positions for a multitude of reasons, which of course we have different work streams in the Moving Forward Coalition kind of targeting the workforce issues. And the other struggles here, let's be honest, is that not only have we had a one-size-fits-all approach where you go into every single facility for the same amount of time, regardless of what you see or don't see, is we also have had a lack of real-time mobile capability. Even the new, we've had Aspen for years, and even with the new IKEY system, it doesn't work offline. It doesn't work in a mobile capability. So people are having to carry hard, heavy, laptops around, and they're constantly, because they don't work offline, they're having to cut and paste, still do kind of rudimentary kind of electronic manual processes. And it can take weeks to get actual data from a facility that you've even been into. I've worked with many states who are now working on some of these issues to have more mobile technology that they can just later RPA into the federal system. That gives them at least some more near real-time analytics of knowing to where they should send their most precious people resources. The other piece is, let's talk about geography and distance. There are certain places in the US where even to get to the nursing home can take 5 hours of driving, or even inaccessibility during times of snow or issues of weather and different types of road closures. So we really have to think more creatively about even how and where we target facilities, and target facilities in a more concerted way. And so I think what April was trying to describe is we need to take data and analytics to decide where our highest risk facilities are, how long to stay once we're in those facilities based off of what we're seeing, based off of what the compliance history has been, about what kind of changes have recently been in the facility, as well as whatever kind of reviews that we do in advance of going. Having that more targeted approach allows us to be in more places more often, and being able to use, again, those precious human resources that unfortunately we cannot 3D print, create a new public health nurse to go in or train them immediately, but using those precious resources in a more targeted and prescriptive way. And really welcome everyone here for their questions and thoughts as we are building this together. This is definitely supposed to be a collaborative process, and hope that you are interested in this even more as we build out phase 1 and phase 2, so you can be a part of some of the kind of tactical decisions that need to be made about how we want to create these pilot approaches. I am happy to say that there's been multiple different states that have kind of looked at this and said, hey, yes, we want a pilot, whether it's with a region or a county or an area, to be able to get some data on whether or not, this could be something that could be very effective moving forward. So happy to see the excitement and the people involved both at the state level as well as the different patient advocates, legislators, and others and in the industry who are interested in seeing how we can do this better.
That's great. Thank you so much, April and Heidi. Thank you for that really wonderful overview. And we're back to the gallery view here so that we can really get going with some conversation. If it's okay, I wanted to start by just addressing a few of the questions that are in the chat. I responded in the chat to some of them, but early on in this call, Senator Richard Moore, who we worked together when he was in the state legislature and I was in elder affairs here, he raised some very, very good questions and points about the survey process. And I know April did respond in some way by saying a lot of these things are actually currently part of our year 2 work. So even though you didn't see the detail in the action plan itself, we had to balance the action plan content and the amount of content because some of the people who are reading these action plans are much more familiar with the survey process than others. But we wanted to really try to balance it so that people who don't know very much about survey could at least get the general sense of what we're trying to do here. Some of the things, looking at, meeting federal and state guidelines, that's already part of all of the surveys. And by the way, Heidi can jump in here and April can jump in because Heidi has experience as a survey director more recently than my experience, which is now, going on 15 years old. Taking into account things about ownership transparency or, what are the other companies that are part of the constellation of services and programs, so that if you're looking at, the data on who actually owns the nursing home, we have a better way to understand about some of the other companies that are sometimes they have different names, they have different structures, and it can be very hard to track where the money is going. And we've had an entire committee. I know Isaac may want to jump in here because he's been working very closely with that committee. But we've had an entire committee that's just focused on those relationships, what's in the cost reports, how can we understand the cost reports, the state reports, the federal reports. It gets complicated very quickly. But I do want to just reassure this group that we agree it's an issue and we want to keep working on it. You may know that CMS has recently done some work on this also, which we believe is a good thing. It means they know it's important. They're taking steps. But there will be more about that ownership data in the second year. And again, all of that relates to, the financial reports being audited and so forth. The question that you raised about, what is harm or the absence of harm, some of the people on this call may know about. There's a grid in the enforcement process that's called the scope and severity grid, and it's a CMS document. It's an official part of the survey process. And again, that's where it describes different levels of harm, actual harm, an individual who's been harmed versus something being widespread versus it being, facility wide. And so we did not take on that scope and severity grid specifically, but we did address the issue of harm versus no harm. And April can say more about that. This is a long-standing issue. And again, having been at CMS and having been the person who got these questions, myself and our team, it's definitely true that a lot of people want to look at that scope and severity grid and say, is it still relevant? Is it the best way to approach this? Does it really differentiate where we need to? Do people use it consistently across regions and across state survey agencies? So again, it's a very important issue, and April can say more about that. Timely responses to resident and family complaints. This is one of the reasons for having a survey like this one is, again, whether it's a 2-day survey or a 3-day survey, whatever it, we find out through the testing works, it should free up surveyors so that more surveyors can dedicate their time to addressing complaints from residents and families. That's part of the reason for doing something like this. It's so that a survey agency as a government entity can better use surveyor time and dedicate that surveyor time to the nursing homes that are lower performing nursing homes or, to places where there's a lot of complaints. So I'll stop talking now and ask Heidi and April, do you guys want to add anything to what I said or change anything that I said?
No, I think Alice, you did an awesome job. And I think for individuals, like Heidi and myself, that's the world we live in with the grid and understanding the definition of harm. And what we have worked really hard with is in this proposal model for the targeted recertification is we're not going to look to change what the definitions are that already exist. So using those consistent definitions that are scope and severity grids in a survey process that's already defined by rule is looking at the inclusion criteria to allow initially to start as a targeted resurvey would be if a facility has not had a harm or higher in the grid in the last 3 years. And I know that there's always discussions amongst everyone about, well, there's other areas and other ways to define harm. What we need to do with this group is stay very focused in what is the parameters and definitions that we have within the state operations manual already, and looking at what are those criteria. Same with some of the quality measure risks. We're going to be working with our phase 2 to determine, but we're not going to create new. We don't have the bandwidth to create new quality measures. So we'll be looking for what CMS already uses within that. The one thing I didn't describe is what we've also proposed in the action plan is if, for example, a facility met criteria, and our criteria that will, if our proposal comes through the pilot, will be if on like day 2, the survey agency have identified areas that potentially could be in those categories of harm or higher, the facility will continue on the traditional recertification process. So if something's identified by the survey agency in that very focused couple days that says, hey, we've got something that could be a higher level, they will continue the regular survey. So it isn't that I met this facility A met criteria for a 2-day and that's it no matter what. And that's what part of the year 2 will look at is what are those trigger points? What is and what it is not. But we're going to be very focused on staying within the parameters that CMS has already laid out within the state operations manual for surveyors. And that's where Heidi's expertise comes in, is being the surveyor on the other side. I'm on the provider lens. And fortunately, our group has individuals that are advocates as well as research individuals. So, and then getting our state agencies and associations voice in that, I think is going to be really clear. And most importantly, getting our residents' voice as we pilot this. And do we get them in our process? So.
No, and I just wanted to add too, I think Alice, you did a great job of, we are all very well aware, right, that change of ownership is an issue, which is why that's a flag, right? Unfortunately, every single state has a different reg for how they are managing change of ownership. And even in a strict state, like, let's say in, California, they have new change of ownership rules. Even then, if I were to ask my team, get me the complete compliance list of a particular provider who might have several different facilities, because of the lack of AI and technology that the states have, at first it took an analyst 6 weeks to get a full compliance report because of all the shadow companies or this or 5% of this, or, it was very difficult to find fraud and be able to get it. Because of, these paper or manual processes or old legacy databases that everyone is working with. Of course, that has gotten taken down to, only a couple of weeks. But I've worked with some states where they still are so manual in their processes that it's very difficult to be able to find all of the issues with the change of ownership, even when they're trying to decide if a new provider should be able to have a new facility. And again, the laws are different in each state. And so I do love that you've raised that as an issue, because that's exactly why, if there has been a new change of ownership, that's why that's a flag to be able to do a more concerted effort to go through that facility. I think that that's something that we should explore more in our phase 2, as well as what we would maybe offer as potential different policies around this issue.
And thank you guys very much. And Senator Moore is continuing with great questions, and he's particularly bringing up the issue here about, if state survey agencies are behind in responding to complaints or doing annual surveys, which we know they are. Some of them are behind by as much as 30% of the nursing homes haven't been surveyed within the 9 to 12 month window, and some are even farther behind than that. So how is this idea of a retargeting of, a recertification, a targeted recertification survey going to help with that? And are survey agencies still going to fall behind, even if we put this in place? I think, one issue related to that is adequately funding survey agencies. So some of this is literally about having the resources in a particular state, and everybody on this call, I think, is familiar with this, but the resources that each state dedicates to their survey agency and to doing surveys is variable. Some of that's set by CMS in terms of how many surveys they did the year before, and some of it depends on how the state responds and puts in state dollars too. But if we don't adequately fund state survey agencies, we don't have enough surveyors to do the surveys, and that is a separate issue, but it's a really important issue. The funding for state survey agencies across the country has been level or has gone down over the last several years. And again, I see a few people nodding on this call who've done research into this. So that's an issue. The other thing is a lot of states pay surveyors very poorly. And if you're a nurse or a social worker, you can make a lot more money, sometimes close to twice as much money in a job in a health system, for example. And so, how do we encourage people who have the values that we're looking for and the dedication and the skills and knowledge to do these jobs, which are really important jobs? We're not there yet. And a lot of states are even farther behind than some states that have, done better. So, these are all really important points. I hope other people chime in as well. But Senator Moore has really targeted a lot of these issues as being really important. I want to go now to, because Nancy Stevens wrote in something here, also kind of related to the quality of the survey process. And we know Nancy from other calls. She's a nursing home resident, and She says, I have some concerns over those nursing homes that have inaccurately received higher grades from surveyors due to several reasons, such as standing relationships between surveyors and facilities and a lax survey inspection job done. Heidi, I don't know if you want to respond to that, but that is not a singular complaint. We've heard that, from other people as well. And I think it varies state to state, but even though there are, regulations and guidelines that are very specific in terms of making the role of surveyors clear, what they can and cannot do. And maybe you want to mention about some of those things. There are times when people cross the line, and we know that happens. So do you have thoughts on how we can address that particular issue?
Yeah, and I want to go ahead and go back to about what you were saying about the funding first, because I think that's a key issue. So I can tell you from previous experience that about 1/3 of my California state agency budget was covered by CMS, yet they were asking for about 2/3 of my total work. So they were basically giving me about half the amount of budget that I needed to be able to get to all the facilities and do all of the things that they asked. And I see this going on across the US, where it's about 1/3 of each state agency's budget, and the rest is either augmented by the state budget, general fund, or in California's case, we had a system where we would charge a licensing and recert fee to every facility. So it's basically getting subsidized. Facilities are subsidizing what CMS should be paying for in the first place. That is a real issue as far as how to get the work done. And almost everyone is behind in their complaints for the things I just had mentioned earlier too, about the clunkiness of the system, the ability to get to facilities or hire and recruit and retain people that are near or in the region of hard to get to areas, as well as, funding in the first place. But beyond that, I wanted to kind of go on about what you had just mentioned about, these biases, right? Surveyors are human. There's always going to be a bias, no matter how much bias training I do with staff, right? And how much that I do with teams, right? About to try to counteract that. However, there are systems in place with quality control and internal lookbacks that you can be able to do with managers from different regions. So for instance, if I notice that, let's say the San Diego region is having some, that's really interesting. I might have the Chico region double check what they're looking at, right? I might do some different types of things across my state that are completely different areas to kind of make sure that there are ways that people are doing a look behind or looking at if that's consistent. So there's got to be some internal quality controls within the state to kind of counteract that. I'd also say that when you look at data and analytics, regardless of what you see from previous years, you can also normally see trends, right? And so just one pilot that we did in California during the pandemic was we recognized that with 400 surveyors, there was no way we would be able to get to all of the 1,200 nursing homes quick enough if there was an outbreak. In fact, we saw that in April 2020. So we decided that since we had an emergency going on and we didn't have to use the SOM, we decided to completely come up with a new pilot. And we took data and analytics to decide where and when we targeted our highest risk facilities. And so every day I'd give the team a list of 50, and that's where we sent our strike teams. And what we found over time is that we actually had the lowest case fatality ratio in HAIs as well as COVID during this time period by using data and analytics to decide where and when we sent our teams rather than using the CMS schedule. And it wasn't always perfect, I will say that, and that's why I mentioned this as a story, because as we tweak these kind of data and analytics to decide and what are the flags and what are those red flags, as we tweak it with qualitative data that we will get from the surveyors that are going in and using this pilot, we can continue to tweak this to be more accurate and to be more and more effective as we go along. But there are ways that you can use this, and we have so much data on congregate settings in general. And we're already starting to see this in other countries as well, that are starting to think of how do I use these precious resources that we have, limited surveyor resources, to go into congregate settings. And so this is not just a trend that we're seeing here in the US, but I'm also seeing this globally, where people are trying to think more thoughtfully about how and when they target their workforce.
Yep. And I think just to chime in too, I think head on what Heidi was saying, with this action focus group that we're on what is the elements for that targeted resurvey versus a recertification survey. I think when Heidi was explaining this data element platform, that kind of got our thoughts going, is we can use that technology that they developed in the same kind of dashboard method to bring in complaints that are either facility reported complaints. There's a huge volume of those that are under investigated. Facility reports it, and it might be 2 to 3 years later that we actually get a survey on those. Community complaints, survey history, ownership changes, all that comes at our idealism would be that would come to a dashboard that would help state agencies then rank. Where do we need to go quicker? Where do we need to go? Which is their targeted? Which are going to be the traditional? What a number of surveyors that need to go in? Do I need to speed up this process? Right now, there is no dashboard per se that helps the state survey agency manager understand that. And as we have all talked, like what Senator Moore was saying, is the whole focus of this is getting those limited resources into facilities. Providers want that, residents want that, CMS wants that, timely. Let's get those complaint investigations done timely. Let's do the recertifications timely. How do we use that? Right now, just globally, just as a generality, for those that don't know, a recertification survey typically, I don't know, there's no dates prescribed, usually takes 5 to 7 days. I don't know, that's just general. Could we do it in 2 days? Use those resources, get those complaints done more timely. That's really the focus, is appropriate uses to get the lens where we need to, and then get, more importantly, that resident voice in the survey process and address those issues. I think were posted, Nancy Stevens posted, is we need to do better at making sure when we do resident interviews, how do we get those interviews? How do we get their responses in a method and way that feels safe and open and is fluid? And that will be part of this process as well. So I've got a lot of elements, and it's very exciting going forward. That will be flushed out within the next year as we then begin to pilot towards the end of this year. The framework needs to be set first.
And I just want to highlight also, so thank you guys for responding to these really good questions. Deanne Walters wrote in about, as a provider, the bias can go both ways. Some surveyors arrive in a facility determined to give a deficiency before even walking in the facility door. Others have developed a relationship of trust with the facility leadership. And I think that illustrates the challenges that we have collectively, all of us together, in recognizing human bias, and that it can be part of this. Nancy wrote in about law enforcement wearing body cams, and the survey agencies and CMS saying we're not going to record surveys. So that seems like a bit of a dichotomy. So how does that work out? Are there newer technologies? And again, Isaac and Sumeri are on this call, and they can speak about our technology, health information technology committee, but all of the committees in moving forward have had aspects of technology brought up and AI brought up. And so we don't want to go in that direction just because it seems like a cool new thing. That makes no sense. But if there's a way that technology or newer platforms or devices can actually help and promote more consistency across surveyors and across survey agencies, that could be something to consider. There have been issues raised also, across CMS, what we used to call the regional offices. Now it's, CMS Atlanta, CMS New England, whatever. But, those localized CMS branches, there's some pretty big differences in how those federal surveyors, determine deficiencies or citations. So if you live in a particular state, you might be much more likely to get cited for certain things than if you live in another state. And again, I know I've got a couple of Leading Age colleagues on this call here, and Leading Age every year comes out with a sort of top 10 report, which is the top 10 survey citations by state, for example. And so, this information gives us patterns and certainly does support this idea of variability. It's about variability, and these are human beings who are going out on survey. They're working very hard. It's a very hard job. For those of you who've never been out on a survey, it is a very hard job. And so figuring out how to support that so that we get the results that we all want, which is to differentiate nursing homes that are providing adequate quality or even high quality from nursing homes that are not. So I don't know, Deanne or Nancy, if you want to say anything more about your comments, but if you do, please, we can unmute you, or you can come off mute and add anything else to the conversation.
Well, and I also want to add that I appreciate Senator Moore's comment about the star rating. I can say that, we originally started with different data points, as I mentioned in the pilot that I mentioned that California did. We found that star rating had no bearing, really, no statistical bearing on whether or not a facility was going to have a massive COVID outbreak or massive death from that. What we did find, which will not surprise anyone on this, is that one of the most key data drivers was staffing ratio. So obviously, if you have a high staffing ratio, you have people that you can cohort patients with, you have more people to be able to train and cross-train, you have people who have the time to don and doff between patients or wash hands between patients, et cetera. So no surprise there that staffing ratio has been a key data driver that I see when it comes to quality and safety in a facility, as well as leadership and the type of culture that they are creating there around quality and safety.
That's great. And I know that, because it just highlights what do we need to do here? We clearly need to do some more work and do it now in real time, not, years and years from now. I know Nancy also just added in something about the fears that residents and staff, and I would add family members and care partners, have of retribution for speaking up, especially to surveyors, and that needs to be addressed too. And Nancy, again, if you want to come off mute and say anything.
Sure.
One of the most common things we do here.
Yeah, thanks so much, Alice, and thanks for including a resident's voice on these issues. I can only really speak to my own personal experiences, and I won't go into too much detail, but there was an instance when the Partners in Care Foundation ended up contacting or filing a complaint on my behalf. And the surveyor who came in was basically taunting me while I was on a trauma therapy appointment. He refused to leave the room. And then he called in my CNA and told her to just stand there with him and don't say anything. And they stood there for about 20 minutes while the surveyor literally laughed at some of my responses while I was in tears, talking about some of my past traumas. And then I was when my trauma therapy session ended, and the surveyor started asking me questions and interrupting me while I was trying to respond at the first or second sentence of my responses, not as if I was going on and rambling, sort of like I am now, based on nerves. But yeah, he just would not let me speak. And I asked if I could possibly get a friend of mine who was witness to what had happened on the phone. And he claimed that I was interfering with his investigation by recording him.
Yeah. So, again, very powerful story, Nancy. And, that's a lot to take in for us. But we do hear from residents. I think a lot of people on this call know this, but maybe not everyone. We've had Dr. Barbara Bowers from the University of Wisconsin, along with Sumeri and Isaac and others, have done interviews and focus groups with many residents. Again, Nancy's one of them. We also have Jeanette Sullivan Martinez on our call and possibly other residents with us as well today. But, these focus groups and interviews where we've asked very honest questions of nursing home residents and given them what we hope is a very open, transparent forum without retribution, where they have been able to give us their recommendations and ideas. Those ideas and recommendations have been compiled into a report that is being reviewed right now by the steering committee. And, once we revise it in any ways that we need to, we will be posting it so that everybody can see the voice of residents. The information from those groups has actually also been shared with all of the committee co-chairs and has been integrated into the action plans where it's appropriate. And we've heard back from some of the residents that they are very grateful that, we didn't just say we're here listening to you. We actually did, what was happening. We took what they were reporting as their thoughts and recommendations, and really a lot of that got into the action plan. So we are really focused on hearing the voice of residents on these calls, on any of our other calls, integrating that into our action plans in the work that we're doing in year 2. And there's much more that we need to do because a lot of nursing home residents don't have any way of getting to us. We need advocates in the communities. I saw Bev Laubert was on the call earlier. Oh, she's still on, from ACL and the, long-term care ombudsman program. And Bev, I don't know if you want to say anything about the role of ombudsman, but I just think this issue of making sure with the survey process, because this call is about the survey process, but with the survey process, do you have anything that you want to add at all in terms of residents being able to be more engaged with surveyors or anything else?
Yeah, we hear from ombudsmen that residents are not regularly engaged with the survey process and the need for support for residents to feel comfortable speaking up. I've also heard from ombudsmen that residents are hesitant to speak up about the concerns they have, and which is why it's doubly important for there to be consistency in survey agencies involving the ombudsman at the required points. And that's not happening consistently either, where ombudsmen are to be contacted before the survey, at entrance, participate in exit, and so on, and to be available for participation in the group resident interview if the residents choose that, because the ombudsmen are regularly talking with residents, frequently talking with residents, and if they can be there when the surveyors are there, they can help, lend them some credibility and help encourage those residents to speak up about the things that they've been saying to the ombudsman, or the ombudsman can, talk in this resident group interview about the things that residents have said, generally speaking, without identifying individuals.
Other people have thoughts on that? I know I see a number of advocates and other folks on the phone who may want to chime in. Kathy just chatted in about, Kathy's been a really active member of the quality assurance group, and, stressing the idea of this particular plan is to figure out the focus on the resident input and looking for actual implementation of care plans, which is the focus of the goals, priorities, and preferences action plan also. And that group is, they're meeting at the end of this call, and we met with them yesterday too. So lots of work on that. And Nancy pointed out that the sort of echoing what Senator Moore said, that, a lot of the concerns that are expressed are coming from people who live in nursing homes that are between 3.5 or 5 stars. So higher star ratings suggesting better quality. But there have certainly been a number of people around the country who've, called into question the 5-star system and what it represents. Other thoughts? Again, one of the specific things that we're interested in, Sumeri, Isaac, and myself, is as we're in year 2 and we're diving deeper into this work, and we're doing more detailed work that we've not been able to do until now. So we're transparent about that. We want to know your suggestions. And again, this conversation today, and of course we're recording the call, so we'll have it, is really, really helpful, because this is giving us additional direction and some additional ideas. But specific thoughts from anybody else about, ideas for this group, ideas for the coalition as we do more of this work. What Lynn wrote in, would a surveyor's code of ethical conduct be helpful? Heidi, is there something like that now? Maybe it's not called that, but do you have thoughts on that?
There is, and that does exist already. And surveyors are trained on that. I think it really comes down to accountability, again, internal accountability within the state systems. And that's really what it comes down to. But that does exist. It's more so about accountability. I see, let's see here.
Yeah, Deanne wrote in about, more timely feedback about the surveys, essentially. So, you do the survey, you get what they call the 2567, which of course is just the number on the form, which is ridiculous, all of that. But they get the report from the surveyors, and, there isn't always follow-up with the nursing home in terms of what they can do or how they should proceed. And the same thing about the conclusion of complaints. They either say, it was substantiated, not substantiated. So
pre-pandemic, it would take surveyors, and I would walk with them. I actually went and did, boots on the ground, pretended I was a surveyor with them, did the whole process with my team, because I wanted to see the time to task and understand where all the bottlenecks were and how complicated and frustrating using iKeys and Aspen and the electronic survey model epochs and all of that was. And with so much cut and paste and moving back and forth, because again, like I said, it doesn't work offline, it would take 2 weeks. Well, that's not great, right? For the facility to not even have that information, as well as for me as a state survey director, I want to have at my fingertips current data on where are the highest risk areas, what's going on, what do I need to escalate, etc. And so we did switch during the pandemic to a mobile app. And having that mobile app gave me real-time analytics. I could see exactly pictures, dictation. I could pull stats and analytics from the back end of that app. And so having that mobile app that then, CMS said, well, how are you getting it into our system? Because CMS doesn't allow, for integration. We just use robotic process automation. So we did RPA to be able to pull everything from a mobile app and dump it into the federal Aspen and iKey system. And that worked 100 times faster and easier to get real time. We need more of that across the board, because if you don't have that ability to provide information back and forth or have bi-directional communication, then we maintain this carrot and stick, kind of attitude or operational practice from the state, which doesn't help survey quality and safety or for the residents or patients. So the facilities themselves appreciated that they could log into this portal. They could see instantly what their plan of correction options were. They could be able to enter their plan of correction electronically. It could go back and forth with bidirectional communication, and all of it was tracked and logged, and they could see where it was in the process as far as getting final approvals and being sent. Having bidirectional communication with facilities is paramount to quality. We cannot continue to just throw out a CMS memo or a facility letter from the state saying, here's the new reg, go have fun. There needs to be able to have that bidirectional Q&A or bidirectional technical assistance that's separate from the surveyors themselves.
Mhm.
We want people to be successful, but we also have to set them up for
Right.
success with that opportunity to communicate.
Right. So Sumeri and Isaac and I were going to ask you guys about some of the technical aspects related to this action plan, but Heidi just did a beautiful job talking about them. So looking at the time with just 4 minutes left, I wanted to give Jane Carmody from the John A. Hartford Foundation, who's our funder, an opportunity to just say, anything that you would like to wrap up here with Jane, and then we'll turn it over to Sumeri to close us out.
Well, thank you, Alice. I'm so glad that I joined. I love the website. I love that you're explaining each action plan by video. So I've loved that, and I've loved the discussion today. And as I kind of noticed, it was difficult to get here. I mean, to sort through that huge report for the National Academies, which was so well done, and then to get to 9 areas that could really make a difference, focus on. And now I'm realizing the complications in doing each one. And I know we'll do it. And I know with the people on these calls and the people involved will really make it happen. So I'm just sending a gratitude and appreciate the work going forward, and appreciate the difficulties. I shouldn't say difficulties, challenges, maybe going forward. Opportunities, that's the new word. But I do, yes, opportunities. And that is right, Alice. They are opportunities, but my goodness, this is going to make a difference. And I love the voice that everyone has been providing today. So thank you for allowing me to join.
Awesome. Sumeri, over to you to close us out.
Thank you, Jane and Alice. I wanted to share a big thank you to April and Heidi for sharing about the action plan today. And another thank you to the committee members who have been and are working towards implementing this action plan. Thank you for your leadership in this work. And thank you all for joining us today and sharing your thoughts and questions. I thought this was a really powerful conversation. And you may be wondering how you can continue to stay engaged and stay in touch with the coalition. And I would recommend, if you haven't had the chance yet, to start with reading the action plans. We can chat that in again. And consider how your organization could get involved as well, potentially. I know in each of the action plans, we've outlined needed partners and resources and opportunities for collaboration. So if you are interested in any of that, do email us at info@movingforwardcoalition.org, which we can also chat in. To stay in the know about the coalition's latest progress and any upcoming events like this one, do join our newsletter and follow us on our LinkedIn page. And lastly, we'll continue to have these coalition conversation webinars. We've been having a webinar to highlight each of the action plans. And the next one will be next week on August 8th, focusing on the action plan about enhancing surveyor training on person-centered care, which we will share in the chat as well. Thank you all for joining us today. We hope we can see you in future calls. Isaac, Alice, do you have any other final thoughts?
Just a big thank you to Sumeri and Isaac for their tremendous organization behind all of these calls all the time. So thank you. All right, great to see everybody. Thank you all so much. Thanks, Heidi and April.